So I'm here to present my abstract on fully integrated mental health management within routine HIV, adolescent and young adult services using a collaborative care model in our clinic in Bangkok called See You Buddy, which I know some of you have actually been to, and if you're visiting Bangkok, you're welcome to come and visit us. Right. No conflicts of interest to declare. So the background of this is approximately 1 in 5 of Thai adolescents and young adults living with HIV have mental health disorders. And Thailand has only 8 mental health professionals per 100,000 population, which is much smaller than the global average and in Europe. And in this study, we aim to provide a fully integrated collaborative care model for mental health care in routine AL-HIV clinic services to improve access for teenagers trying to access mental health care. So this is divided into 2 phases. The first phase was between 2018 and 2019. We conducted this at our adolescent clinic, which specializes services for youth aged 15 to 24. We routinely screened everybody for depressive symptoms using the PHQ-9 questionnaire, and anybody scoring over 9 or having suicidal ideation or having symptoms consistent with major depressive disorder were referred to a psychiatrist. And so we didn't manage any of their mental health issues in clinic. After that, we moved to phase 2, and this is a bit of a busy slide, so I'll take you through this. So this happened between 2020 to just last year, and we had a mental health specialist or a psychiatrist, and the rest of us, we have a mix of, some of them are sitting here, there's counselors, primary care team, so peer educators, some of them are also sitting here, and HIV doctors. And so we had a care team that were managing the mental health care of the adolescents and a psychiatrist that was supervising all of this. And so the collaborative care model, if you've never heard of it, you may be thinking, what is that? So it's actually a collaboration, in other words, task shifting mental health care from a mental health care specialist to the primary care team that primarily deliver care to the client, the patient, with shared care plans that incorporate what the patient wants, so patient goals. And so we did this in our clinic to provide all mental health care instead of taking them to another clinic. And this really consisted of the 3 things that you see on the screen. So capacity building of the staff, because of course, all of us being infectious disease people, we had no idea what to do with some of the very severe mental health cases at first. And we were trained with counseling, how to use basic psychiatric medications. And of course, after that happened, if you don't have practice, it's very difficult to then implement that. So we had monthly meetings with a psychiatrist, we discussed patients, and then make a joint decision about how we were going to manage specific cases. And we also had protocol-driven care, and I'll show you an example in the next slide of what I mean by that. So all of the initial care was provided by the clinic staff, including the emergencies. And if anybody needed to be sent off to the psychiatrist, there would be case managers from our clinic that would go across with the client or patient. And this is just an example of what I mean. We initially had 5 medications, and this was a protocol that was written for us by our supervising psychiatrist, and we ended up using only 3. And you can see on the screen, really simple. If they have mild depression, use sertraline. If they have moderate to severe, move to escitalopram, and add an anxiolytic if they have insomnia. So really straightforward. And the concept in this clinic really is that you can see in the beginning that when somebody goes into depression, they dip down. And once they start responding to care, we can really, the care team in the clinic started looking after them right from the start and through to the remission and the recovery. And in between there, if you've looked after people with HIV, you'll know who have mental health challenges that sometimes they'll relapse. And throughout that, it's either we or the psychiatrist would look after the case. And so they were supported throughout this process. And this continuity of care really helped to reduce the stigma related to people asking them, well, why are you not at school? Why are you not at work? So that kind of avoided it because we tried to integrate this into standard services as much as possible. So what did we learn? So in this model, in the from 2018 onwards, we looked after just over 300 adolescents, about half and half between people who acquired it perinatally and during adolescence, median age of 18, and approximately 1 in 4 had some kind of mental health disorder diagnosed. Most of them were about 80% were major depressive disorder, small number of people with bipolar disorder, and the striking thing was that people who were diagnosed with depressive disorders, about a quarter of those attempted suicide, actually attempted. And so this was quite overwhelming for us in the beginning, and it took a lot of coaching for us, and now we're much more comfortable with dealing with this. And so you can see in phase 1, every single person had to be looked after by psychiatrists, which was completely unsustainable. And by the second phase, we'd reduced this to just about 1 in 3. And about half of them achieved remission using this method. About 38% are in ongoing care. And the rest of them, even though some people refuse care, are still in follow-up for other adolescent services, because we provide a comprehensive care service in our clinic. So really, in conclusion, we saw 3 main things that we learned from this model of care. So number 1 is improved access to mental health care services, because like we've heard from our young person today, the rapport between the staff is incredibly important. And when they have people that they trust that are assessing them, it was very helpful. It reduced clinic visits. And for the healthcare providers, we were very overwhelmed in the beginning, but the monthly meetings really helped us to build capacity and made it more sustainable in the long run. In terms of applications, we're currently trying to adapt this to other youth-focused services, especially in low to middle-income countries like our settings, and we're currently also doing cost-utility analyses to see if it's a cost-effective intervention. So that's all I had to say. Thanks for your attention, and thanks for staying until the end.